So our last speaker before lunch break, which I think is sitting at the back right now, is a tag team effort. So Dr. Callie Barrett is an intensivist and a clinical associate at the University Health Network in Toronto, and you've heard Callie speak about some of her work in terms of the health economics of sepsis. She's going to be tag team with Fatima Sheikh. Fatima is a health research methodology PhD student here, co-supervised by myself and Lisa Schwartz. And Fatima and Callie are going to talk about their work leading into sepsis policy, but specifically talking about what we can learn about sepsis policy elsewhere in the world. So Callie and Fatima.
Okay, hi everyone, my name is Fatima, and as Allison suggested, I'm a PhD student at McMaster University, and I'm in the Health Research Methodology program. This is a very different talk from what we've heard so far, but I think really relevant as it ties in a lot of the different studies that we've heard to date, and especially today because it is World Sepsis Day. So I'm excited to give this talk along with Callie. In terms of what we're hoping to get through today, I'll provide a little bit of background and rationale for why sepsis policies are important for us to think about and consider. I'll talk a little bit about the different phases that we've thought out and conceptualized, and these are various studies that have either been done or are ongoing. And so I'll start with phase one, which is the analysis of Rory's regulations. I obviously don't need to go over this slide. I feel like we've seen some version of this slide at least a million times over the last few days. But just to highlight that sepsis does have a significant burden. And as we saw over the last few days, a lot of the current sepsis studies focus on establishing consensus on the pathogenesis and treatment of sepsis, which is incredibly important. But we also have to recognize that in most patients, sepsis begins outside of healthcare settings, and that really highlights the need for public health and policy measures to reduce infection rates and improve early detection in our emergency departments. And so the objectives of today's talk, we'll talk a little bit about Rory's regulations and specifically the ideas, interests, and institutions, as well as external factors that led to the passage of Rory's regulations. And I'll provide some definitions of what I mean by ideas, interests, and institutions shortly. I'll then pass it along to Callie, who will describe an ongoing scoping review / environmental scan. It's a hybrid study that looks at existing sepsis policies, clinical practice guidelines, and health professional training standards in Canada. And we'll conclude by talking a little bit about our proposed next steps. So can I just get a show of hands who here, and if you're on the sepsis policy working group, you can't raise your hand, but who here has heard of Rory's regulations before today? Okay, awesome, that's great. So just really briefly, there are a few different components to Rory's regulations that I'll highlight, and these are just some of those components, but it does require New York State to adopt and implement evidence-based protocols for early recognition and treatment of sepsis in each of those hospitals, to train staff appropriately to implement sepsis protocols, and then there's also a reporting component, so collecting and reporting quality measures related to the recognition and treatment of sepsis that are reported back to the New York Department of Health. And so while Rory's regulations were the first example of state-mandated regulations in the United States, 2 other states, Illinois in 2016 and New Jersey in 2018, have implemented similar regulations, and 15 other states have implemented similar policies or programs in the US. But I don't think sepsis regulations and policies are specific to the US. A lot of other countries have implemented similar policies, including Australia, the UK, and Ireland. And not only have they implemented similar policies and programs, but they've demonstrated reported improvements in the recognition and treatment of sepsis. And there are no similar policies in Canada, and I think that really positions this work well. And so in this first phase of the project, we looked at Rory's regulations. It's done in the US, our counterpart, and so understanding, what the facilitators and barriers are important for our understanding. And so the question we asked was, what role did ideas, interests, and institutions play in influencing the passage of Rory's regulations in 2013, and specifically in the state of New York? We use something called the 3I plus E framework. So the 3I plus E framework refers to ideas, institutions, and interests, and the E stands for external factors, which I think is really important in the context of Rory's regulations, and I'll explain why shortly. We looked at various data sources, including your traditional academic databases, as you would in a systematic review. We also looked at publicly available policy documents and government websites, and then news media, including Factiva, which is a fantastic multidisciplinary database, including current and archived news articles. So you'll see here up on the right a brief and oversimplified definition of what we consider in terms of institutions when we're thinking about policies. But essentially, these are the formal and informal rules, norms, precedents, and organizational factors that structure political behavior. And so this includes consideration of things like the government structure, policy networks, and policy legacies. I'm only putting up the Department of Health here, not necessarily to speak to their role within Rory's regulations, but to state that the Department of Health and the responsibilities of the Health Commissioner really facilitated the passage of Rory's regulations. It was clear who was responsible for implementing policies, who had a mandate and actually had the authority to do so, and that was critical, and I'll explain why shortly. When we think about policy legacies, you can imagine if a state has implemented a policy and it's gone poorly or if it's gone well, how that might influence or shape decision-making in a different state. In this case, New York was the first, and so they had a real opportunity to set a precedent and to be the first. It also meant that they weren't working off of, a flawed foundation. And so that really facilitated the passage of these regulations. When we think about interests, we think about whose interests are reflected in policies, who's at the table, and perhaps the question we might want to ask is whose voices aren't at the table. But in terms of interest, we think about the agendas of societal groups, elected officials, civil servants, researchers, and policy entrepreneurs. So I think really critical to this discussion is the Rory Staunton Foundation, and some of you may know this as End Sepsis now. They were an effective lobbying group, and I, again, will provide a little bit more context for why, and it will make sense if you know the story. But it was effective lobbying, specifically with hierarchical ties. So just as a reminder, I mentioned earlier that, they knew who the health commissioner was, and he played a critical role. So it was lobbying, but lobbying with the right people in the right ways and at the right time. And that was really reflected in the decision to move forward with Rory's regulations. And then you would imagine when we think about healthcare policies, we have to think about and consider the role of healthcare professionals. And, recent literature since the passage of Rory's regulations, there's papers in JAMA that actually caution against policies and perhaps question why a policy is necessary if protocols are put in place. And so really early on in the development of Rory's regulations, they had put together a multidisciplinary advisory group to help inform the policy, and clinicians had early input about the elements that were most important, but they had also engaged, healthcare leadership, the folks that would be responsible for reporting the data and ensuring that that process was in place. And then when we think about ideas, we think about the knowledge or beliefs of what is and views of what ought to be. And when we think about research evidence, we think about, was there evidence to support these policies and regulations that were implemented? So just as a real quick reminder, these regulations mandate the use of protocols which require timely fluid resuscitation, antibiotic administration, and frequent assessment of hemodynamic response to therapy, some of which we just heard in the previous talk. At the time these policies were actually implemented, there was certainly evidence to support the efficacy of early detection and treatment of sepsis. That's likely a take-home message we'll all take away after this meeting. But there was less known about the impact of government-mandated regulations. Was this actually the optimal way to improve sepsis detection in hospital settings? And, while I talk about ideas, interests, and institutions, I think external factors played a pivotal role in the passage of Rory's regulations, as the name suggests. So in April 2012, the story goes, Rory, who was a otherwise healthy boy, went to school, was playing basketball and got a cut. He later fell ill, went to his pediatrician on multiple occasions, and then went to the emergency department. And despite the multiple visits, unfortunately, his signs and symptoms went unrecognized, and he passed. And so this is something we refer to as a focusing event, and in this case, it's the passing of Rory Staunton. And I would go as far as to say, the potentially preventable death of Rory Staunton. And this was very well publicized and sort of led to the advocacy by the Stauntons. Before I summarize these policies, I think it's worth noting that, when we think about the Canadian landscape and what we want to do here, and recognizing, what really facilitated those policies by way of Rory passing away, I think it's worth noting that we shouldn't have to see another child die or another loved one die for us to be considering policy measures. So when we think about some of the facilitators over and above the focusing event, the fact that, a multidisciplinary stakeholder group was convened, clinicians, hospital representatives, epidemiologists, and data science experts all had influence and input into these policies. It was strategic data collection, so at the time, SEP1 was also in place, which would require additional data collection, and so what they did was ensure that the collection of data at the New York State level would actually complement the federal data collection, as opposed to sort of overlapping. And there was flexibility, particularly amidst evolving science and breadth of focus, and I think something that was really highlighted in the pandemic was that, evidence changes over time, and we need to be amenable to that and be able to adapt appropriately. While Rory's regulations were passed, there's certainly barriers that were identified in doing this review. The first is quite obvious in the sense of failure to justify the need for a policy response. It takes a lot of time, years, and a lot of stakeholders to implement policies, so identifying if that is the most appropriate response. And the last is a lack of coordination with existing policies. So Rory's regulations were the first, but at the same time, SEP1 was being developed, and so coordinating that early on was an effective strategy, but could be a potential barrier if not considered in other jurisdictions. And so I'll just conclude this section by saying that, obviously the institution's interests and ideas and their interplay influenced Rory's regulations. It was really highly influenced by the passing of Rory Staunton. I'm going to pass the mic over to Callie, who will talk a little bit about our current jurisdictional policy review and our proposed next steps for evidence-based policy recommendations.
All right, so that was a fantastic overview of sort of the framework that we have to work with when we're looking at the evidence, looking at what's out there in terms of policy, but then also keep in mind when we're proposing potential policy, and then keep in mind that this is in the complex Canadian healthcare system, which is an even higher level of complexity. So the purpose of this study, and the team consists right now of Victoria over there, who's Sepsis Canada funded student, and Fatima. So the three of us are working on this project. And so we decided that we wanted to really get a sense of what's out there. And so we're doing a scoping review to determine and describe the existing sepsis policies that exist, the clinical practice guidelines, health professional training standards, as well as look at any potential threats or opportunities for sepsis policy development. And to make some recommendations. And let's go to the next slide. Oops. Specifically why we're looking at so sepsis policies, this is to identify, are there areas where there's a really well-developed jurisdictional policy about the identification, management of sepsis, clinical practice guidelines, like we know there's the Surviving Sepsis Campaign guideline, but are there more sort of regional recommendations for how sepsis should be identified, treated, et cetera. And then the health professional training standard, we thought that was incredibly important, given that it's clinicians and health professionals for the most part who are responsible for recognizing sepsis. So are we training our health professionals appropriately to be able to identify this? And not really included in here was also hospital accreditation. So do the accreditation documents require that sepsis is something that the hospital policies include? So we're doing a scoping review and environmental scan. We're using sort of the routine clinical databases, as well as this really awesome TRIP medical database, as well as Policy Commons, and then hand-searched multiple websites. So the Royal College of Physicians and Surgeons of Canada, the Family Physician College, I'm sorry, I forget the name of it right now, the nursing accreditation organizations, paramedic training organizations, accreditation organizations. So we went really broad, and also went into accreditation type websites as well. So we went very broad, and we identified a fair amount of evidence that I'll show in a minute. So we've limited it to since 2010. The purpose being, if you go back too far, you're going to start getting policy that's no longer relevant. And also, the way we treat sepsis has changed over the past sort of 30 years so much that we thought this was, we don't want to go back too far. We want to make sure that we're identifying relevant policies. And we're scoping, or we're including anything really very broad. So anything that reports on policies, guidelines, or standards specific to the identification, management, and or reporting of sepsis in Canada. And it had to be, so for the websites that we sort of hand screened, they had to be publicly available or really easily accessible through a reasonable request. We found most of them were, and available in English or French. So we are at the full text screening point. So results will be out soon. So you can see quite a lot of hits in the, quite a lot of hits in the sort of standard medical literature and policy comments. We then screened 1,335 records, and there were 54 for full text screening, and we're now doing the full text screening on an additional 90. So when this is done, where we hope that this evidence will help us is that it will really help us understand what are the policy and training gaps presently in Canada. Where do we need to start working in terms of policy development? Have we identified any potential barriers or opportunities? And then we're going to use this to help inform future policy recommendations and development. Which I'm going to go to the next part. So where are we going to go from here then? What do we do next? So the first thing that we're planning to do is we're going to write a policy review based on the evidence that we've generated through the scoping review. We're going to clearly describe sort of where there are effective sepsis policies in Canada, where there are policies that exist that aren't very effective, important policy gaps, i.e. are there areas here that we need to be developing policy, and then we're going to be so bold as to suggest where policy should be developed and make some recommendations for areas where the policy, like the areas about the policy that should be developed. Then I would really hope that myself, Fatima, others in this room, others with Sepsis Canada will help with this work. I think we should be the ones leading the sepsis policy development in Canada. I'll give a very good example. I practice medicine in the province of Ontario. There is no quality standard from Ontario Health for sepsis in the province of Canada. What a great place to start, right? So we could work with Ontario Health to help develop a provincial quality standard. What's also a great opportunity, the Surviving Sepsis Campaign recommendations include things like follow-up clinics and, checking in with people afterwards. So maybe we should be suggesting care pathways for patients after they leave the ICU. That, it's recommended in the guidelines, so let's help develop those care pathways. That's where I think we should be going as well. And that's, a plug for my other work. That's part of the reason I'm doing the policy or the economics work, because we can then have an economic justification for why we need to be developing these care pathways. And then I think we also, as has been brought up today, help support the development of policies and programs that don't presently exist. So the care pathways that I mentioned, but also registries, follow-up clinics. This can be some of the stuff that we get going, and clearly there's people in this room that want to make that happen. So let's, connect with me when we have our work done. But I think the scoping review that we're doing is really setting the groundwork for a lot of really exciting and important policy development that we would like to lead, and that Sepsis Canada really should be leading, and I think CIHR expected us to. So that is where we're at, and we are keen for questions or thoughts. So we just want to acknowledge our team, so everyone here on the room who's helped, and also this is a part of Fatima's PhD, and there's our contact info.
Thanks very much. It's a lot of work that have gone into it so far. One question I have you spoken to Rory Staunton's parents or the New York Health Commissioner, Marcus Friedrich? Okay, because I think speaking to them will give you a very good idea how this started and where it went. And the reason is I've worked with them very closely. In fact, I was involved in some of the policies and also in the first study we did in pediatrics in the New York data with the most kids in the world. And I was also involved in the Irish policies and those things with Leo Varadkar, who became Prime Minister, was Minister of Health. But a lot has to do with Karen and Oleg Staunton, because we traveled together to Ireland and kick-started that. And the New York one is really, the reason I say this is because while there's the rigor of science, it also came with a bullheadedness that really embarrassed politicians. And if you talk to the UK group, the very same thing, Jeremy Hunt, who was the Minister of Health, was embarrassed there. Australia, the same thing. When you look at Switzerland, Sweden, I can give you again and again all the thing. And Marcus Friedrich is the New York Commissioner who is for patient quality and safety, who led some of the effort of putting together the studies together, which I've been part of for a long time. So if you'd like to speak to any of these individuals, I have all the contact information and would be very happy to introduce you so you can sort of get a first-hand information as to what was done. Thanks.
Yeah, no, that's fantastic. Thank you very much. And I think that also speaks to the sort of the issues that Fatima brought up in her review of the Rory policy, was that you can't just develop policy. You have to have buy-in from the stakeholders. The people that are going to receive this policy have to understand that this is important. So that's why it's not just as simple as writing a document. There has to be, the government needs to think that this is important. The clinicians that are being told that, perhaps their clinical practice maybe doesn't meet standards, that's very threatening